I'm Anne Woolfield.
I'm Mel and Anne.
And I'm Carla Pecoraro, and we're your hosts of the Uterine Sound Podcast, bringing you up-to-date information on all things O&G.
Today we'll cover perineal tears and obstetric anal sphincter injuries, otherwise known as OASIS.
Now, this is something that a lot of women are really worried about. We really don't enjoy the idea of having any kind of tearing or cuts to our vaginas, which I think is very understandable. But what are the actual chances of some kind of perineal tearing happening during birth? And, Stats Queen, hit me with some stats.
About 80% of women who give birth vaginally will have some kind of perineal injury. Now, most of these tears will heal well without any long-term issues. We tend to more worry about our third and fourth degree tears, and the chance of that happening is much lower, about 3%. The incidence of these tears also really depends on whether this is your first vaginal delivery or not. Women having their first vaginal birth have about a 5% chance of OASIS, but for women who have had a vaginal birth before, this risk is less than 2%.
And for those new to obstetrics, let's have a little refresher on the classification of perineal tears. A first-degree tear involves the perineal skin or vaginal mucosa, like a graze. A second-degree tear involves the perineal muscles. Third and fourth degree tears involve the anal sphincter complex and are what we are talking about when we use the term OASIS, or obstetric anal sphincter injuries. Third degree tears include the internal or external anal sphincters and are subdivided into 3A, where less than 50% of the external sphincter is torn, 3B, where more than 50% of the external sphincter is torn, and 3C, complete thickness of external sphincter and damage to internal sphincter. Fourth degree tears are again deeper and involve the sphincter complex and the anorectal mucosa.
We also have something called a rectal buttonhole tear, which is kind of its own little category, and while it sounds adorable, is really a sneaky little beast that tries to escape detection. A rectal buttonhole tear is where the anal sphincter is intact, but there is damage to the rectal mucosa above it. These tears can be really difficult to identify without a rectal examination, but it's super important that they don't get missed because if we don't repair these tears, they can lead to fistula formation and fecal incontinence.
I've also heard that if there's any doubt about the degree of a third degree tear, it's better to classify it to the higher degree rather than to the lower degree.
That's right. And to give credit where it's due, this classification system was developed by Dr. Abdul Sultan, a consultant, obstetrician and gynecologist in the UK, and was accepted for worldwide use in the early 2000s. Now, this guy is pretty much the guru of all things OASIS. He's published about 1 million articles on anal incontinence and sphincter injuries. If you want to feel inadequate about your resume, check out this guy's list of publications.
The true peri-godfather. Now, what is it about third and fourth degree tears that makes us so stressed? I mean, my sphincter is tightening just thinking about them.
Well, speaking of sphincters, the anal sphincter plays a huge role in maintaining anal continence and is essentially the reason why we can hold in our farts and number twos when we really need to. Any damage to the sphincter, like with a third or fourth degree tear, can significantly increase the risk of anal continence, with some studies reporting a 39% risk even after sphincter repair. Now, to understand why the anal sphincter is so important in maintaining continence, we really need to talk anatomy. The internal sphincter is made of a longitudinal smooth muscle and is under autonomic or involuntary control. It maintains continence at rest by contributing 70 to 80% of the resting anal pressure. Damage to the internal sphincter results in passive soiling and flatus incontinence, which basically means leaking of feces or wind without warning. The external sphincter is a striated muscle innervated by the pudendal nerve that is under voluntary control. It maintains the squeeze pressure of the anal canal and allows us to voluntarily hold everything in. Damage to the external sphincter results in urge fecal incontinence.
And I just voluntarily squeezed my anal sphincter, my very smart, clever and wise anal sphincter that can tell the difference between liquid, solid and gas. Thank you, sphincter.
We also worry about third and fourth degree tears because they're much more likely to lead to complications, particularly the increase of anal incontinence. Short-term complications include things like perineal pain, edema, bruising, urinary retention, defecation problems, and wound dehiscence. Long-term complications include fistula formation, dyspareunia, anal incontinence, and chronic perineal pain. Not to mention the psychological complications, which can include feeling vulnerable, exposed, or embarrassed, psychosexual dysfunction, and the feeling of being socially isolated, which is particularly important for women in developing countries.
I think it's really important that we are actually talking about this topic. This episode is so important. And to summarise what we've learnt so far, OASIS refers to obstetric anal sphincter injuries and is classified by the Sultan classification. First degree is perineal skin or vaginal mucosa. Second degree, perineal muscles. 3A, less than 50% of the external anus sphincter. 3B, more than or equal to 50% of the external anal sphincter. And 3C, complete external and internal anal sphincter. Fourth degree is anorectal mucosa. The overall incidence in Australia is 3%, 5% for primates and less than 2% for multis. Third and fourth degree tears can lead to short-term complications like pain, dehiscence, and urinary retention, and long-term complications like dyspareunia, fistula formation, and anal incontinence. So how can we make sure we're identifying anal sphincter injuries when they occur?
Recognizing anal sphincter injuries at the time of childbirth is incredibly important. We know that women who have a sphincter injury that has been appropriately identified and repaired at the time have better outcomes than women who have an unidentified sphincter injury that doesn't get repaired immediately. We also know that the anal sphincter can be damaged from the sheer force of the baby's head coming through the birth canal, even in the presence of an intact peri. For these reasons, the current recommendation is to do a digital rectal examination for every woman after a vaginal birth. Without a digital rectal examination, perineal trauma, including anorectal injuries and buttonhole tears, can be easily missed and lead to severe consequences for the woman.
Oh, wonderful. As if having a baby isn't hard enough, we then get rewarded with a finger in the butt. How do you actually go about doing this exam and asking women for their informed consent?
I found most women are actually quite accepting of a rectal examination once you explain what you're doing and why you're doing it. I usually say something like, is it alright if I check if you've got any tears? Part of doing this is to see if you've got any tears towards your bottom muscle, which involves a finger in the bottom. Is it okay if I do that? Of course, the woman can always say no, and it's important that we respect that, but it's also important she understands why we're doing the examination. And if we don't do it, there's a small risk that there might be an unidentified tear that doesn't get repaired properly, could lead to things like fecal urgency, incontinence, or fistula formation.
And I think this is where wording is so important. If you say to someone, so I'm technically supposed to do a rectal examination, but your peri looks fine to me, so I really don't think you need it. Do you still want me to do one? Well, of course, no one is going to say, oh, yes, please. I think most people do want to make sure they don't have any damage to their sphincter and are quite accepting of an examination to check for that, particularly once you explain what it might mean if you were to miss an OASIS injury. Of course, there may also be certain circumstances where a rectal examination is unacceptable to the woman, in case her decision to decline an examination should be totally respected.
Yeah. DRE involves inserting one finger into the rectum to check the anal tone, as well as the integrity of the anal sphincter. It's important that we do not miss a rectal buttonhole tear. The external anal sphincter fibers tend to run horizontally, whereas the internal sphincter fibers tend to run vertically. It can be also helpful to roll the external anal sphincter between your index finger and thumb to check its bulk and identify for any divots or defects. You can also ask the woman to squeeze your finger and check for anal tone. This examination is usually quite quick, but it can be uncomfortable, so I usually offer the nitrous and administer some local anaesthetic if there's no epidural on board. My goal is to identify the tear and arrange appropriate management while causing as little discomfort to the woman as possible.
It's also really important to get a second clinician to examine the tear with you. I've read that we tend to pick up more OASIS when we look at it with a second pair of eyes. We want to pick up more sphincter injuries so we can repair them and prevent anal incontinence.
That's absolutely right. And this is why there's a bit of controversy around using OASIS as a measure of obstetric performance. So I'm not sure if you all realize, but hospitals all have to report on their rates of OASIS, and there can sometimes be financial penalties if your rates are higher than other hospitals. Now, obviously, we want our rates of OASIS to be low. Clearly, we want to be reducing the incidence of OASIS. But hospitals that report higher rates of OASIS aren't necessarily causing more tears. It might just be that they are better at identifying them, which is actually a good thing. Basically, we want to prevent OASIS happening in the first place, but if it does occur, we want to make sure we detect it and fix it.
And how good are we at detecting the tears? Do we have any idea about how often we're missing them?
Now, several studies have tried to address this question by using endoanal ultrasound to look for the presence of sphincter defects. One study, which looked at women 2 months post-delivery, reported the incidence of anal defects in primates to be as high as 30%. Other studies have shown that midwives and doctors can miss 87% and 27% on OASIS injuries, respectively. Now, this study was quite a while ago, and our training, prevention, and identification of sphincter injuries has improved a lot since then. But I think it just goes to show that we're not perfect, and getting a second pair of eyes to check on the peri can make the difference between an undetected injury that leads to incontinence and a detected injury that can be repaired.
Far out. That is just so alarming. I didn't know the numbers were like that. Has anyone thought about using ultrasound at the time of delivery to diagnose OASIS?
Yes, actually. So 3D endoanal ultrasound is actually considered to be the gold standard investigation for the detection of anal sphincter defects in people who have anal incontinence. So naturally, people have explored the idea of using ultrasound immediately after birth to help minimize the chance of undetected sphincter injuries. Unfortunately, research into this so far has not supported this, and for now, immediate postpartum endoanal ultrasound does not seem to add additional value beyond a routine clinical examination by an experienced clinician. The other things to consider with trying to use endoanal ultrasound at the time of birth is having availability of probes. We already know how hard it is to just have a TV probe, let alone an endoanal probe that would need to be sterilized. You would also need to have adequately trained staff who can actually perform the ultrasound, but also staff who can interpret it, and it still needs to be acceptable to the woman.
And also, what if you do find a sphincter defect in a woman with an intact perineum? Should we be taking them to theatre and dissecting down to the sphincter to repair it? I think the answer to this isn't yet clear. I await Dr. Soltan's expert opinion on this. So, we've covered what an OASIS is, why it's important, and how to detect it. Let's get down to business. What do I need to know to be able to repair these sphincters properly?
Okay, there's a few things we need to prepare for our repair. First, adequate analgesia. You can use a regional anaesthetic like an epidural or spinal, or a general anaesthetic. Technically, you can repair an OASIS under local anaesthetic or even a pudendal nerve block, but the spinal or GA tends to relax the muscles more, which may make the repair easier.
Next, we need good lighting and adequate equipment. Sometimes the edges of the external sphincter can retract into the lateral tissues and be really difficult to identify. Decent lighting and Alice forceps can be used to help grasp the edges of the sphincter complex and bring them together for repair.
We always want sterile prep and drape, and in general, OASIS should be repaired in theatre. However, there are some situations where it might be okay to repair the tear in birth suite. For example, a small 3A tear with adequate lighting, good analgesia, and a decent exposure. This just lets mum stay with her family and the baby while we repair the tear. And beyond a 3A, though, really we should be transferring them to theatre.
It's such a shame when you have to take the woman to theatre and take her away from partner and baby.
Yeah.
I think this is really what the women find most distressing. Like, surely we can find a way to facilitate mothers and babies to be in theatre together for a tear repair, especially if it's happening under a spinal or a GA.
I absolutely agree. If anyone has been able to keep mums and bubs together in theatre for a tear repair, please let us know. We would love to get that going in our own workplaces.
The other thing to remember is antibiotics. Most hospitals in Australia have a guideline of a stat dose of cefazolin and metronidazole at the time of repair. The evidence for this comes from an RCT that compared the effect of a single IV dose of a second-generation cephalosporin on postpartum perineal wound complications, which found that antibiotics reduced the rate of OASIS wound complications from 24% to 8%.
Wow, that's pretty good.
Right, so where does the metronidazole come from?
Interestingly, there's actually no studies that have specifically looked at the role of metronidazole with OASIS. Some patients are also sent home with oral broad-spectrum antibiotics such as Keflex and metronidazole or Augmentin Duofort for 5 days. There's actually no good data to support this practice either. Despite this, several guidelines still include the recommendation for IV cefazolin and metronidazole at the time of the repair and a course of post-operative antibiotics.
It's very important that we have someone experienced to repair the tear. This is not the kind of injury that you would get your resident to suture. This is especially important in the case of a 4th-degree tear. In these situations, you want to get an experienced consultant or a urogynecologist or colorectal surgeon to be available, but most O&G consultants are quite capable of repairing these tears. It's helpful to know that repair of a 3rd or 4th degree tear can be delayed for up to 12 hours if you really need to. For example, if there's nobody qualified to repair the tear, if you don't have an anaesthetist, or if there's no theatre availability. And this might be particularly important if you're somewhere rural. Obviously, this is less preferable for the woman, and you should really try and repair the tear as soon as possible, because delaying the tear repair can result in an increased risk of blood loss or infection. But sometimes it can be helpful to allow transfer of the patient to somewhere with adequate facilities if required.
Okay, so we need good analgesia, adequate exposure, lighting and equipment, theatre, sterile prep and drape and antibiotics, and an experienced surgeon. How do we actually repair the tear?
We always repair the deepest injury first, so either the anal rectal mucosa or the internal anal sphincter. The anal rectal mucosa should be repaired with a 3/0 vicryl, including a continuous or interrupted technique. We used to say that the knot had to be tied inside the anal canal, but this was when we used to use catgut. Now that we have different suture materials, this is no longer necessary. The Green Top guidelines suggest that we don't use PDS for the anorectal mucosa. This suture takes quite a long time to dissolve and can result in rectal discomfort and irritation. Although some guidelines suggest that a 3/0 PDS can be used, we suggest you follow your local hospital policy. All guidelines agree that a figure of 8 sutures should not be used on the anorectal mucosa because they can cause ischemia and poor wound healing. The internal anal sphincter should be repaired with interrupted or mattress sutures using a 3/0 PDS or a 2/0 vicryl in an end-to-end technique. You really shouldn't try and overlap the internal anal sphincter. Separate repair of the internal anal sphincter significantly improves the likelihood of subsequent anal continence.
And the internal sphincter is one of those really tricky sphincters that I think most people don't often identify. So I think it's something you really have to look for. You have to know where it is and what it looks like. And most people describe it as like a chicken kind of material, looking like, vertical up and down fibers. But if you imagine that it's going to start a centimeter or 2 above the external anal sphincter, and it's also only going to be about 3 to 5 millimeters thick, if you look for it, then you can see it. But sometimes it can be really tricky to identify. Now, the external anal sphincter is also repaired with a 3/0 PDS or a 2/0 vicryl and can be repaired with either an overlapping technique or an end-to-end technique. We'll put some images up to explain both of these techniques on our Instagram page because they're a little difficult to go through in a podcast. The overlap technique can really only be used for full thickness external sphincter tears as they allow the torn ends to be overlapped without tension. For partial thickness tears, an end-to-end technique repair should be performed. Make sure you bury your knots underneath the perineal muscles, as this reduces the risk of knot and suture migration to the skin, which can occur in up to 7% of OASIS repairs. Now, there was a Cochrane review in 2013 which compared both the overlapping and the end-to-end technique, and they found no difference in perineal pain, dyspareunia, or flatus incontinence. There was a reduction in fecal urgency and anal incontinence with the overlap technique at 6 weeks to 12 months, but by 3 years, there was no difference between the two techniques. So currently, there's no strong evidence to support recommending one repair technique over the other. Although I tend to prefer the overlapping technique for full thickness tears, I find it gives better bulk, and I think I would prefer less incontinence within the first 12 months if it was me. Once the tear is repaired, we do another rectal examination, but this time we do it to check the sphincter bulk and also to make sure we haven't put any unintended sutures through the anal mucosa. If there are any sutures through the anorectal mucosa that aren't meant to be there, then these need to be removed as they could lead to rectovaginal fistula formation, which can cause anal incontinence and can be difficult to repair.
All right, so anorectal mucosa is repaired with continuous 3/0 vicryl. The internal anal sphincter is repaired with 3/0 PDS or 2/0 vicryl with interrupted mattress sutures. The external anal sphincter is repaired with 3/0 PDS or 2/0 vicryl with either the end-to-end or overlapping technique. And what about after the repair? Is there any kind of post-op management we need to do?
So apart from antibiotics, other components for post-op cares for OASIS include AA, BPF, analgesia, aperients, bladder care, physio, and follow-up. For analgesia, we typically chat Panadol and ibuprofen as required. A stat dose of PR Voltaren can also be used, and it's been shown to reduce trauma-related pain in the first 24 hours after birth. Avoid this with the 4th-degree tear because rectal analgesia could theoretically disrupt the wound. We tend to avoid opioid medication because it can be constipating. Ice packs can also be helpful to reduce swelling and pain.
Aperients are also very important, and a lot of women are really scared to go to the toilet after a tear repair. I tell women that this fear can be very normal, but that it's really important that they open their bowels regularly and make sure they aren't straining. There actually has been a study comparing a laxative regime with a constipation regime. The thought was that bowel motions in the immediate post-operative period might threaten the integrity of the repair, so it might be better to not use your bowels. Unsurprisingly, the constipation regime resulted in significantly more constipation, which even resulted in hospitalization for fecal impaction in some patients. The laxative regime was associated with significant earlier and less painful first bowel motion and an earlier hospital discharge postpartum. There's also been a study comparing the use of lactulose alone or lactulose and a bulking agent. This study found that women taking the bulking agents as well as the lactulose were more likely to have incontinence in the immediate postnatal period. For this reason, we usually prescribe lactulose alone and advise the patient to titrate the dose, aiming for soft formed stool.
Toothpaste consistency. You'll never look at toothpaste the same ever again.
No, thanks, Carla. With third and fourth degree tears, severe perineal discomfort is known to cause urinary retention, with a delay of up to 12 hours before bladder sensation returns. Urinary catheterization should occur following a third and fourth degree tear repair, and we should ensure a normal trial void after IDC removal.
Now, that is something that seems so obvious. Like, you always think, oh, no, you've had a tear to your bottom. It shouldn't possibly affect your bladder. But it's actually the pain and the damage to the nerve muscles that can cause you to have that urinary retention. So, yes, these perineal tears can lead to urinary retention.
That does make sense.
So physiotherapy is another essential aspect of care. So we'll usually ask a physio to review the patient while she's in the hospital. And at that visit, the physio will provide advice on defecation techniques, pelvic floor care, and ongoing support. Pelvic floor exercises are essential in maintaining sphincter function and reducing the risk of fecal incontinence. They can be started straight away if the physio is happy that the correct technique is being performed, or if the physio assesses the patient and thinks she's not quite doing the pelvic floor muscles properly, it might be better for the patient to not do pelvic floor exercises until her tear is healed, and then she can have some biofeedback in the clinic in 6 weeks to do the exercises properly.
With follow-up, it's important to debrief the woman on the nature of the tear and its prognosis. Most facilities will review women with sphincter injuries in an OASIS or a gynae clinic at 6 to 12 weeks to check for healing and any ongoing symptoms or concerns. At this visit, if there are concerns, then an anorectal manometry or endoanal ultrasound can be arranged and referral to a physiotherapist and colorectal surgeon if ongoing fecal incontinence or pain.
So what's the prognosis for third and fourth degree tears? You've mentioned that there's a risk of anal incontinence, but how likely is that to occur?
It's actually really hard to find decent numbers on this for a few reasons. Firstly, anal incontinence can occur many years after childbirth. Secondly, many women are embarrassed or reluctant to report it. And thirdly, we don't have many great studies on this. The Green Top Guideline reports that 60 to 80% of women are asymptomatic 12 months following delivery. However, some of them will develop symptoms that only become apparent years after the injury. In general, women with OASIS are 2.6 times more likely to develop anal incontinence in their lifetime. In the general population, about 8% of women and men report anal incontinence, but the prevalence of anal incontinence after a primary repair of OASIS is reported to be somewhere between 15 and 61%. The more severe the injury, for example, a 3C or a fourth degree tear, the more likely a woman is to experience anal incontinence. It's also important to note that women's continence over time may be affected by aging, subsequent deliveries, and also lifestyle factors.
And what does this mean for the next pregnancy?
In general, women with a significantly increased risk of anal incontinence are typically offered a caesarean section. For example, if they've had a fourth degree tear, current symptoms of anal incontinence, ultrasound evidence of anal sphincter defect or low anorectal manometric pressures, psychological or sexual dysfunction, or women with 2 or more previous OASIS. They are at 10 times increased risk of OASIS.
That is wild. 10
I
times.
know.
Far out.
If the woman doesn't have any impaired sphincter function or symptoms, then the vaginal delivery isn't necessarily contraindicated, but she would, of course, have the option to either have a vaginal delivery or a caesarean section if she prefers. Ultimately, the decision regarding delivery route is made by the patient. The majority of women with a previous OASIS will not have recurrence in their next vaginal delivery, and so women without the above risk factors may reasonably be offered a vaginal birth. But there are a few facts to know. A woman with a previous OASIS has about a 5% risk of recurrent OASIS. Women with a second OASIS have about a 70% increased risk of anal incontinence. Women with one OASIS who go on to have another vaginal birth have about a 17% chance of worsening fecal symptoms. So an argument exists that all women with a previous OASIS should be offered a caesarean section. If every pregnancy was delivered by Caesar, then pelvic floor dysfunction would certainly be minimised, but not completely obliterated. However, caesarean carries much higher risks for the woman and should not be considered routine care for all women.
And then I guess from that side of things, are there any, is there anything evidence-based that women can do to prevent them from getting an OASIS? What kind of things can we do to prevent these kinds of injuries as well?
Prevention of OASIS is something we really try to focus on in obstetrics. The first step is being aware of the risk factors of increasing the chance of a sphincter injury. Some of these risk factors include having your first vaginal birth, previous OASIS, being of Asian ethnicity, babies over 4 kilos, being in the OP position, shoulder dystocia, prolonged second stage, instrumental delivery, particularly forceps, having a midline episiotomy, increasing maternal age, and vaginal birth after caesarean section or VBAC. The risk of recurrence would be particularly high for an Asian woman delivering a 4-kilo baby by forceps delivery. Being aware of these risk factors makes us a lot more attuned to the possibility of a sphincter injury, and as a result, we become a lot more protective of these perineums.
And we need to talk about instrumental deliveries and the risks, because I know it's different based on forceps or a vacuum, isn't it?
That's right. So the highest risk of OASIS and also anal incontinence occurs with a forceps delivery without the use of an episiotomy, and the lowest risk of OASIS occurs with a vacuum with an episiotomy. Obviously, choosing the right instrument for an assisted vaginal delivery is important, and it would be great if we could just choose a vacuum for all assisted deliveries, but it's important to remember that forceps are an important instrument and sometimes the best choice and safest choice to deliver the baby. We'll go into the pros and cons of vacuums and forceps in another episode. It's pretty clear that choosing a vacuum over forceps where possible and using an episiotomy for instrumental deliveries can reduce the risk of OASIS.
Okay, so to make it easier for everyone, let's create a profile of a patient with almost all the risk factors. We'll call her Leslie. Sorry, all Leslies out there. Leslie is a 42-year-old Asian lady having her first vaginal baby, and it weighs 4 kilos. She has a prolonged second stage because her baby is in the OP position, and she ends up needing forceps. Unfortunately, somebody drops the episiotomy scissors, so she ends up having a forceps without an episiotomy. Once the head comes out, there's obviously a shoulder dystocia, and we need to make an episiotomy to do our internal maneuvers. In the heat of the moment, somebody cuts a midline episiotomy.
Oh no, I think having this lady on the birth suite would definitely make all our own sphincters tighten.
Yes, and I think in obstetrics we all like to think of ourselves as peri-godmothers, and we get so sad when women have these tears. Peri-godmother Mel, tell us what we can do to protect these peris.
There has been a lot of research into ways we can prevent perineal trauma, and basically we can divide it into antenatal prevention and intrapartum prevention. So what can we do before labour and what can we do during labour? Antenatally, there seems to be some good evidence of perineal massage and pelvic floor muscle training. A 2013 Cochrane review assessed the effects of perineal massage, defined as 3 to 10 minutes of intravaginal perineal massage with almond oil 3 to 7 days a week, starting at 34 weeks gestation until delivery. This review showed that in patients without a previous vaginal birth, perineal massage resulted in a 9% reduction in perineal trauma requiring suturing and a 16% reduction in episiotomy use, although there was no real difference in overall rates of tears.
For those in the audience who aren't quite sure how to do perineal massage, check out our Instagram page during the week for a how-to. Now, I've seen some ads for things like the EpiNo or various devices women can use themselves to try and stretch the peri to reduce the chances of trauma. Do these devices actually work?
The EpiNo device is used to help stretch the perineum antenatally from 37 weeks. It's shaped like a little water balloon, placed in the vagina and then blown up to stretch the perineum. The idea is that you can stretch the perineum over time to help accommodate a baby's head without tearing. Unfortunately, the evidence doesn't seem to support these devices, with the 2016 RCT showing no difference in the incidence of OASIS. Pelvic floor muscle training is another thing that can be done antenatally. Doing pelvic floor exercises every day can reduce urinary incontinence in the late pregnancy and 6 months postpartum, and it's been shown to shorten the first and second stage of labour. But there seems to be no difference in the rates of episiotomy or perineal trauma. There have been some studies looking into combination interventions, so daily antepartum massage plus twice daily pelvic floor exercises from 32 weeks. Together, these interventions result in a 31% less chance of episiotomy, higher chances of an intact perineum and lower OASIS rates, less perineal pain, and less postpartum analgesia.
Okay, so we've spoken about what we can do before labour to reduce the risk of tears, antepartum massage and pelvic floor exercises. What can we do during labour to save our peris?
Intrapartum prevention techniques include intrapartum perineal massage, choosing a birthing position, selective or restrictive episiotomy, warm compresses, and perineal protection at crowning. Intrapartum perineal massage is performed in a similar way to antepartum perineal massage, but is typically done by the midwife or doctor in the second stage of labour. Intrapartum perineal massage has been shown to reduce the risk of OASIS and episiotomy and to increase the chances of having an intact perineum. Although it's important to remember that the perineum may be particularly sensitive to touch during birth, and some women may value avoiding this procedure during labour over reducing the risk of perineal injury. It's worth discussing with the woman antenatally and at the time of labour to see what they would prefer to do.
Birthing position is also really important. There's a higher chance of perineal tears or OASIS in lithotomy, sitting, squatting, and birth stool positions. A better position to give birth in might be on all fours or in the kneeling position, which have the highest chance of an intact perineum. The standing and lateral positions also have the lowest chance of OASIS. In general, support women to give birth in whatever position they find comfortable, but let her know the benefits of the all fours, kneeling, lateral, and standing positions.
Warm compress is also a simple and well-accepted method of reducing the risk of OASIS. It involves applying a warm compress, typically between 38 to 44 degrees Celsius, to the perineum during the second stage of labour. Warm compresses have been shown to increase the incidence of intact perineum and lower the risk of OASIS and episiotomy. It can also increase comfort during the second stage of labour and has been shown to be acceptable to both women and midwives. Most facilities are quite good at facilitating warm compress, but I do find it is easy for this to be overlooked during the second stage of labour when there's a lot going on. Keeping the water at the right temperature can also be difficult. A few things I've seen work quite well include using a turned-off sterile rice cooker and filling that with warm water and then replacing it when the water cools down, or having a heater box in the room, like a blanket heater, and having warm saline or warm water in the heater box that you can use. Usually the warm compress is held against the woman's perineum during and in between pushes in the second stage of labour. If you have any suggestions of what's working well for you in your own facilities, please let us know.
And what about perineal protection? I've heard a lot of debate lately about hands-on versus hands-poised approach. What's the latest on this?
It's a bit of a controversial topic, and there's been a lot of research looking into this. With a hands-on technique, the midwife or doctor puts gentle pressure on the perineum with one hand and gentle pressure on the baby's head to slow the delivery of the head and keep the baby's head in a flexed position. It's usually associated with advising the mother not to push when the head is crowning, instead to breathe through as the head delivers. The theory behind manual perineal protection is to reinforce the perineum and distribute the perineal tension over a wider surface area. It can also help the passage of the fetal head by keeping it flexed and allowing the smallest diameter to pass through the perineal structures. Although the theory of this seems to make sense, there's a surprising lack of randomized trial to actually support perineal protection. The latest evidence seems to be moving away from the hands-on approach. The most recent systematic review and meta-analysis we could find actually suggests that a hands-on technique during a spontaneous vaginal delivery results in a similar incidence of intact perineum, first, second, third, and fourth degree lacerations. But the incidence of OASIS and episiotomy actually appears to increase with the hands-on technique. Despite this, perineal protection manoeuvres remain in clinical practice and is still part of intervention programs and bundles that have successfully reduced the incidence of OASIS.
Interesting. It's so important that we keep up to date with the evidence and keep an open mind to changing our practice. We need to use a scientific approach and look at everything and take it on face value without bringing our own biases to the table.
Absolutely. And I mean, there are so many changes that we've made over the years thanks to new evidence. And one of those changes is episiotomies. So in the past, and in some countries today still, episiotomies were considered a routine part of labour management. All women would get an episiotomy. Thanks to evidence showing a lack of benefit and an increased risk of complications with routine use of episiotomy, the rates of episiotomy have declined over time. We no longer do episiotomies for every woman, but there is definitely still a role for a selective episiotomy. A selective episiotomy means restricting the use of episiotomy to certain clinical circumstances. These would include instrumental deliveries, especially forceps, where there's a need to expedite delivery of the baby and the head's being obstructed or blocked by thick perineal tissue. In shoulder dystocia, not to relieve the bony impaction, but where you might need to create some space to get your hands in for your internal maneuvers. In women who have a history of female genital cutting, or where the development of an OASIS seems really imminent. For example, if you can see that perineum is blanching and starting to tear already down the midline, then you may want to do an episiotomy to direct that tear away from the important sphincters.
When performing an episiotomy, the technique is incredibly important. Mediolateral episiotomy is preferred over midline, which increases the risk of OASIS. To cut a mediolateral episiotomy, the incision is made at the vaginal introitus, at the fourchette, and cut at a 60-degree angle from the midline when the fetal head is crowning and the perineum is distended. This results in a 45-degree angle once repaired, which avoids cutting through the sphincter. Estimating the angle can be quite difficult, so you can use episiotomy scissors which have the angle built in. However, they can be quite expensive. Another simple way is to use the umbilical cord clamp, which conveniently, when it opens up, sits at 60 degrees.
Now, a lot of these techniques have actually been bundled together into something called the WHA Collaborative Care Bundle. Bundles are typically a group of interventions put together to try and reduce the risk of certain conditions, in this case, OASIS. The aim of the bundle was to try to deliver all elements of the bundle to over 95% of women having a vaginal birth, with the goal of reducing the rates of OASIS by 20% by 2019. What are the elements of the WHA Collaborative Care Bundle, and what were the outcomes of this?
The elements of the care bundle include things we've already discussed, so a warm compress, 38 to 44 degrees during the second stage of labour at commencement of perineal stretching, slow, controlled birth of the head with a hands-on approach, episiotomy, using the correct technique for all women having instrumentals in their first birth for all forceps or at other times when there's clinical concerns of tearing. A PR examination for all women after a vaginal birth and having the trauma graded by 2 clinicians. The results of this bundle so far have been quite promising, showing a 13% reduction in tears, 18% fewer tears with instrumentals, and 24% fewer tears with forceps. Data continues to be collected and the elements of the bundle will continue to be revised to make sure we're providing the best care to women.
Okay, so if I want to do everything physically possible to protect my perineum, I would start pelvic floor exercises twice a day and do antepartum perineal massage twice a week from 32 weeks. I would try to give birth on all fours, kneeling, standing, or in a lateral position. And I would try to avoid lithotomy, squatting, or seated positions. I'd ask for warm compresses and intrapartum perineal massage during labour. I'd try and slow the birth of my baby's head and maybe avoid the hands-on technique. And I'd get 2 people to check my sphincter properly to make sure my sphincter has survived. And if it hasn't, I want that little buddy repaired so we can become best friends again and best friends with a physiotherapist. And that wraps up our week's episode on OASIS and on my sphincter, apparently. We hope you've learnt a little bit about OASIS and how to protect those peris.
As usual, you'll find our references on the website and updates on our Instagram page.